Hey guys, my name is Patrick Dwyer again. I'm here to talk to you a little bit more in depth about what a coronary angioplasty is and the technology that goes into it. Just a brief overview of the procedure itself. What it is when a physician is able to access the patient's heart through various points on the body to look for arteries that look like this. The yellow representing plaque. The plaque here is occluding the artery, causing pain and restrictive blood flow. The idea behind the procedure is to go in and put a stent in, which is represented by the black area on this artery. The yellow still being plaque pushed against the side of the walls and now restoring blood flow throughout the heart. During this presentation, I'll be discussing the different access points, radial, femoral, and brachial, as well as the stents of drug-eluting and bare metal stents. As you can see here are the three major access points to the procedure: the femoral artery, the radial artery, as well as the brachial artery. To find your femoral artery, the physician will feel on your inner thigh towards your pubic area to feel a pulse. This pulse will be the access point to complete the procedure. As you can see here, we have the femoral artery accessed. The little white piece that you see coming out, that would be the sheath to access to get the materials in. This is the most popular among physicians because it allows for faster procedures. There's a greater variability of materials that can be used. It allows for repeated interventions. It requires less training because even though there are complications, there are less complications associated with this access. Some of the complications being oozing, bruising, bleeding, swelling, and even temperatures indicating some infection is going on. As you can see here, this is an example of a post-procedure complication. During the procedure, even after, there was a significant amount of bleeding that resulted in extensive bruising and even possibly a hematoma underneath the skin. Now, prior to talking about the radial access point, I would like to have everybody find their pulse first. This is what the physician is going to be looking for to be able to place the sheath. Take your wrist and right by the thumb, put your two fingers and feel for the pulse. This is where the sheath is going to go that the physician is going to be able to obtain access into the body. Now that everybody has found their pulse, this is what the radial access point would look like. It's another popular site for physicians, but the most popular for patients. This site does require an Allen test, which I'll demonstrate for you shortly. This route is preferred among patients because of reduced bed rest times and the reduction of the possibility of a painful clamp being put over a femoral site because of bleeding. This site does carry the same complications, which are same as the femoral artery, such as oozing, bruising, bleeding, swelling, and even risk for infection. There are other complications related to this access, as well as a higher risk of spasm on entry, and since the arteries are smaller, it can be more difficult to manipulate the catheter as needed during the procedure. To perform the Allen test, the patient will first clench their fist. The physician will then apply pressure to the radial and ulnar arteries. The patient will relax their hand, and the physician will look for blanched fingers. The physician will then release pressure and look for the color to return back into the fingertips. If the fingertips flush back with color within 5 to 15 seconds, it is a positive test and they can go ahead with the procedure. If the fingers do not flush back with color within 5 to 15 seconds, the test will not be able to be completed because of insufficient blood flow. The way the physician found your pulse in your wrist would be the same way that the physician would locate the brachial artery in your upper arm. This would be the access for the physician to be able to complete the procedure. This is the third and final access point, the brachial artery. It is least commonly used among physicians. The procedure, however, is performed the same as the radial and the femoral. Even though this is the end of the procedure, this is what it would typically look like, and this access point does carry the same complications as the radial and femoral access points. Now that the physician has successfully gained access into the patient's heart, have found the blockage causing the problem, they have three options. They can either do a drug-eluting ballooning, a drug-eluting stent, or a bare metal stent, and I'll go into greater detail on these three options coming up. The first option an interventionalist has is called drug-eluting ballooning. This is done when a physician feels as though a stent is not necessary. As you can see in the picture, it's done in three steps. First, the artery is accessed, a balloon is deployed, and then a balloon is expanded. As the balloon is expanded, it is also releasing a medication called paclitaxel. The job of this medication is to prevent reocclusion inside the artery. This medication is used because of its rapid uptake and prolonged retention. After the procedure is completed, the physician then designates the patient for a certain amount of time to be observed and then allowed to be released home. If the physician feels as though ballooning would not be sufficient, there are two types of stents that he or she could use. The physician can choose from a drug-eluting stent or a bare metal stent. Once the physician has come to the conclusion that they'd like to place a drug-eluting stent, they would follow the same procedure as ballooning, the only difference being a stent is being placed. These stents are typically coated with the medication of either paclitaxel or sirolimus, and research has shown that these stents provide the best possible care. These stents also do reduce the likelihood of restenosis in the artery. When compared to bare metal stents, they also have a lower mortality rate. Some complications do occur with these stents, such as they reduce the flexibility of vessel and limits the repeatability of the procedure, and also they would have to start taking new medications such as Plavix, Brilinta, Effient, and aspirin. If they don't abide by this medical regimen, they face the possibility of restenosis in that artery. The last option for an interventionalist is a bare metal stent. These were around prior to drug-eluting stents, but serve the same purpose, to restore blood flow to a previously occluded area. Also, they are exactly as they sound, a piece of bare metal. There'll be no medication coating on these types of stents. The patients will also have to go on the antiplatelet therapy with this type as well, with the medications such as Plavix, Brilinta, Effient, and aspirin. These stents, however, do come with more complications. They have a higher risk of reocclusion as well as a higher risk of mortality, and research has shown that patients with these types of stents have had to go through the procedure a second time to reopen restenosed veins. Even during the recovery phase after the procedure is completed, there can still be complications. Some of the complications were listed earlier, such as oozing, bruising, bleeding, swelling, and any kind of infection at the entry site itself. Other complications that can occur are at the stent site, any kind of restenosis, and those signs and symptoms can present themselves such as chest pain radiating, chest pain that stays mid-sternal, anything that could represent a heart attack. After the procedure is completed, the patient usually has to have some lifestyle modifications. If the patient smokes, they should stop. If they drink heavily, they should stop. They should exercise more frequently. They should partake in a low salt diet as well as a low cholesterol diet. In conclusion, the technology in this video has come a long way to provide many benefits for many patients. However, it is always important to make sure that we keep in mind the complications as well as the disadvantages for areas that we can improve technology. I'd like to say thank you for watching and listening to this video. Please fill out the evaluation form in the link provided at the bottom of the video, and thank you again.